All right. I warmly welcome all of you on the IASNM MISSI webinar series. Just a few housekeeping. You can please mute your devices and tabs while during the talk, and you can put your questions in the chat box, or you can do the live session at the end. And now it's my pleasure and honor to introduce Dr. Divya Gurram, who is a second-year radiodiagnosis resident at AIIMS Hyderabad. Her current area of clinical and research focus include breast imaging, including non-breast lesions on breast ultrasound, and also diagnostic accuracy of the MRI or RAD scoring system in the evaluation of ovarian and adnexal masses. Dr. Divya completed her MBBS from Apollo University of Medical Sciences and Research in Hyderabad. And during her undergrad years, she was the class representative for 2016 batch and achieved academic distinction in multiple subjects, including biochemistry, anatomy, pharmacology, pathology, ophthalmology, and general surgery. She passed her second year with distinction and secured first class in her third and final years. Dr. Gurram is also a recipient of the prestigious National Talent Research Examination Scholarship awarded by NCERT for academic excellence. Thank you very much, Dr. Gurram, and without further ado.
Thank you so much, Dr. Muzahir. First of all, I'd like to extend my heartfelt gratitude to all the organizers for giving me this opportunity to present a topic that I'm especially passionate about. And it's especially fitting that I'm talking on non-mass lesions on breast ultrasound during the October, which is observed for breast cancer awareness. So again, I feel very honored and privileged to be given this platform to talk about it. So without much further ado, I'll move on with the presentation. So I hope you can all see my slides.
Yes.
Yeah. So during this webinar, the objectives of this webinar will be to acquaint you all with what non-mass lesions on breast ultrasound is. And I'll be outlining the definition of non-mass lesions, and we'll be exploring the need for why non-mass lesions should be included in the BIRADS classification system and the lexicon. And I'll also be briefly discussing the various classification systems which are already available in current literature. And we'll also be reviewing the various sonographic features of non-mass findings on ultrasound and how we can use these sonographic features in distinguishing benign and malignant etiologies. So what are non-mass lesions on breast ultrasound? So, owing to a lack of unified terminology describing these ultrasound findings, non-mass lesions findings have been described using a variety of terms and phrases in literature. They've been called vague areas of altered ecotexture. They've been called non-mass image forming lesions, non-mass-like lesions, non-mass lesions. So, because of the multiplicity of these terms, there's a lot of variation in the recognition and interpretation of non-mass lesions on breast ultrasound. So although there are various terms with varying descriptors, all the studies, they all agree and they have come down to boil down the definition of non-mass finding on ultrasound to a sonographic finding that does not conform to any mass shape. That is, it has non-convex borders. And especially in the setting of DCIS, where we try to go for breast conserving therapy, non-mass lesions findings are especially important to detect because then the treatment management would be altered in the course of management of DCIS. So ability to recognize non-mass ultrasound findings can improve sensitivity for lesion detection. So the term non-mass finding, it is not currently included in the current breast imaging data reporting and data system, BIRADS ultrasound lexicon. And the current BIRADS descriptive lexicon for findings depicted on breast ultrasound, they only include masses. As you can see in this image, where the masses which are space occupying lesions which are depicted on two different projections. And in all these various subcategories, but that is BIRADS 3, 4A, 4B, 4C, and BIRADS 5, all these lesions have convex borders, and you can also find associated calcification and other associated features like ductal dilatation, architectural distortion, nipple retraction, and skin thickening, and etc. However, radiologists, we often encounter breast lesions that may not meet the exact BIRADS ultrasound criteria. So, why does recognizing non-mass lesion matter? So non-mass lesions are often subtle and they're quite easily overlooked. However, they account for almost 10% of all breast ultrasound lesions. And almost various studies have shown that the incidence of breast cancers presenting as non-mass lesions, it's almost up to 34% of breast cancers. They can present as non-mass lesions. So being able to pick up these lesions in an early phase, it helps to prevent missing any DCIS components and as well as invasive lobular carcinomas. And it ensures that appropriate biopsy is done at an early phase itself. However, the challenges with non-mass lesions is that they often overlap with benign proliferative conditions. So there is also an associated risk of misclassifying these lesions. Coming to what the etiology of non-mass lesions could be. So a lot of large cohort studies which have been done on non-mass lesions have broken down that the main malignant etiology implicated in non-mass lesions is DCIS, ductal carcinoma in situ, and it accounts for almost 37% of non-mass lesions. And along with that, we also have trailing behind, we have invasive ductal carcinoma with a ductal carcinoma in situ component as well. And even invasive ductal carcinoma can present as non-mass lesions. And we also have less commonly, we have other carcinomas such as intraductal papillary carcinoma, invasive lobular carcinoma, and other subtypes such as mucinous and tubular carcinoma also present as NMLs. So what we need to remember when we encounter a non-mass lesion is that we should have a high risk of degree of suspicion when we're looking at NMLs. That it could be a DCIS. So looking for other associated features of DCIS is important, and mixed IDC with DCIS components and papillary carcinomas also should be kept in your differentials when we're looking at non-mass lesions. When it comes to benign etiologies, the main benign etiology implicated is fibrocystic change. Almost half of benign etiologies presenting as non-mass lesions are fibrocystic proliferative changes. And then we have adenosis, and especially sclerosing adenosis trailing behind. And intraductal papillomas, fibroadenomas in the various stages of their evolution, especially involuting fibroadenomas, can present as benign etiologies. And we also have other pathologies such as radial scars, inflammatory pathologies, duct ectasias. These are uncommon but also important mimics of non-mass lesions. So when we think of benign NMLs, the main thing that we have to remember is that it could be a fibrocystic or proliferative change, papillomas, and adenosis. Traditionally, when non-mass lesions have been evaluated, the modalities that have been used, what we first think of is MRI. So the BIRADS defines non-mass enhancement as an enhancing or a small or a large area that is not exactly a mass or a focus. And BIRADS defines the non-mass enhancement under two patterns, mainly that it talks about the distribution of non-mass enhancement, and it also talks about the internal enhancement pattern. So distribution could be that it is focal, it could be linear, segmental, regional, or diffuse. In this image, this is a case of a biopsy-proven invasive ductal carcinoma with a DCIS component, and it presented as a segmental distribution of non-mass enhancement, showing clustered ring, a kind of non-mass enhancement within. So internal enhancement types could be either homogeneous, heterogeneous, it could be clumped, or it could be clustered ring, as in this case. So MR is especially clinically relevant, as in that it is the most sensitive modality for non-mass lesions, and it is quite sensitive in the fact that it detects both multifocality and multicentricity, which is not it's not reliably detected on mammography or ultrasound, and it has a very high sensitivity, but again it has a lower specificity, and it has very high sensitivity in the fact that it helps to detect DCIS, especially high grade non-calcified DCIS. It has a sensitivity of almost about 90%. And it's also good in detecting invasive lobular carcinomas, which have a diffuse spread. However, the limitations of MR is that certain ductal carcinoma in situs, which are a lower grade or have a smaller extent, they may not enhance so strongly, and this would reduce the detection rates. And the lower specificity of MR means that benign proliferative lesions or even inflammatory conditions can mimic non-mass enhancement. And mainly, the limitation of MR is that it's quite costly, especially in the Indian setup. It might have there's limited availability, and it also requires contrast, longer scan times. But this is the most sensitive modality for non-mass lesions and the most commonly used modalities so far for looking at non-mass lesions. Another modality which has been traditionally used for detecting non-mass lesions is mammography. And on mammography, non-mass lesions, they mainly appear with microcalcifications. And this is the most common sign of ductal carcinoma in situ. And you may also see architectural distortion or asymmetries without an obvious mass. And these are often quite subtle findings, and they require magnification views or tomosynthesis for further evaluation. So here we have an image where we can see that there is this subtle area of architectural distortion at 6 o'clock position, and this turned out to be an atypical ductal hyperplasia with a non-mass lesion correlate on ultrasound as well. In mammography, it remains the gold standard for detecting DCIS, especially when it appears in, with a lot of pleomorphic calcifications. And it has a very high diagnostic yield in the screening setting. So it's very critical when we're looking for early breast cancer detection. And as we all know, but it's not very effective in dense breasts where calcifications may be obscured. So in such settings, it's important that we do careful correlation with ultrasound or MRI for a complete evaluation of whatever subtle findings that we have picked up. And coming to the diagnostic accuracy, the sensitivity for DCIS, especially and microcalcifications, it's extremely high, about 95%. So it's very good for calcified DCIS. But again, the specificity, it varies between 40 to 70%. And this is mainly because there are many benign mimics like fibrocystic changes, papillomas, and adenosis. So mammography, really good screening modality, but again, requires careful correlation with ultrasound or MR. Another emerging modality that we've seen coming up is contrast enhanced digital mammography. So how it works is that it combines both low energy images, that is like that of standard conventional mammography that we have, and it recombines them with contrast images that are acquired after iodinated contrast injection. So similar to MR, it depicts both the morphology of the lesion as well as it gives an idea as to the angiogenesis of the lesion. And its role in non-mass lesions is that it helps to enhance the non-mass patterns, whether it's segmental, whether it's a linear uptake, or whether there's a clumped internal enhancement. And it can even help in certain cases where the breast tissue is especially dense. In cases of conventional mammography being a limited factor, when we go for contrast enhanced mammography, it can still help to understand the enhancement pattern and the extent to a certain degree. And it helps to detect again DCIS, invasive lobular carcinoma, and as well as other high risk lesions that may not show an obvious mass. So it's really good in evaluating calcifications as well as the enhancement pattern. And studies have shown that contrast enhanced digital mammography, it has a strong correlation with MRI enhancement patterns. So CEDM is really bridging the gap between mammography and MRI, and it offers quite a good sensitivity and a good specificity for non-mass lesions. And for those patients who are unable to undergo MRI, either that could be claustrophobic patients or they have an MRI incompatible implants, or they're not affordable to undergo MRI, CEDM is coming up to be a good modality for looking at the enhancement patterns in such patients. And also in cases with in patients who have dense breasts, CEDM is again a good imaging modality. So here in this image, we have a case of invasive ductal carcinoma where it can present with two different kind of patterns. It could be either homogeneous or heterogeneous kind of pattern. Given these diagnostic challenges, several ultrasound classification systems for non-mass lesions have been developed in an effort to standardize evaluation and also to refine risk assessment. So one of the earliest classification system was developed in Japan in 2004 by the Association of Breast and Thyroid Sonology, where they've described this non-mass lesions in terms of ductal dilatation, and they've also talked about multivesicular pattern, and they've talked about non-mass lesions being a low hypoechoic area, and which may either be spotted or mottled. They could be geographic, or they may even appear as indistinct low echogenic areas, and they may present with architectural distortion. So as in this case, where we have an irregular ductal dilatation, and we also have certain calcification within them, and there's also some amount of architectural distortion on the image in the right. Then several years later, we had Uematsu and his colleagues publish in the Breast Cancer Journal, and they spoke about non-mass lesions having two broad classifications. One, that they could appear as a ductal hypoechoic area, where they appear with a duct-like structure which is parallel in orientation to the breast tissue, and they may present with either a single ductal hypoechoic area, or it may present as a multiple ductal hypoechoic area. So in this case, we have an irregularly distended duct, and it has a cast-like echogenic component within it. And another pattern that they've talked about is the non-ductal hypoechoic area. Here, where the area has an indistinct shape, and in different projections, it has different shapes, and it lacks a convex border, and it's not very conspicuous. So here again, on the image on the left, you have a focal non-ductal hypoechoic area with a few penetrating vessels within it. And the image on the right, you can see that it's a segmental distributed irregular hypoechoic area with the apex pointing towards the nipple. And they also described about the associated findings of calcifications and architectural distortion. And they also propose that if there are multiple similar bilateral diffusely like hypoechoic areas, they should be considered as normal variations unless the patient actually has a palpable finding. So this multiple similar bilateral areas could be because of either normal variant or hormonal variations. So again, clinical correlation is especially important when we're looking at non-mass lesions. And then again, in 2014, we had Kim and his colleagues talk about non-mass lesions, and they spoke about their patterns and their distribution. This group, they decided to remove ductal distribution because the preceding year in BIRADS lexicon, ductal distribution had already been talked about. So they did away with the ductal distribution. They mainly concentrated on describing non-mass lesions in two different distributions, that is focal, which is less than one quadrant, and regional when it is more than one quadrant. And they even described the internal sonographic pattern with mottled appearance, which is small islands of hypoechoic areas, indistinct when the margins are not clearly defined, and geographic when they're confluent with a cobblestone kind of appearance. Another team, Co and his colleagues, they described non-mass lesions under four subtypes. Type 1, similarly to other authors, they described it as ductal hypoechoic areas with parallel orientation with or without calcifications. Type 2 was again a non-ductal kind of pattern, which is visible as mainly as a confined asymmetry with an indistinct shape, which is seen on two different projections, again with or without calcifications. And type 3, again, we have this vague area of altered ecotexture with associated architectural distortion. And type 4 talked about posterior acoustic shadowing. Then Wang et al. Published in Radiology Medicine, where they talked about hypoechoic areas, mainly the echogenicity of non-mass lesions, and they spoke about sporadic or scattered microcalcifications, and they also spoke about architectural distortion, which is described as a disorganized structure compared to normal tissue. And this is similar to somewhat like the architectural altered ecotexture that we had just talked about in the previous classification. And then we also have solid echogenicity within a duct described. And lastly, we had Park come in and talk about, again, the distribution of non-mass findings, that they could be focal, linear, segmental, they could be regional, and they could have associated features. So all these classifications summarized together, all these authors, they have tried to define what a non-mass lesion is, and they all agreed on the description that non-mass lesions, they're a discrete area of altered ecotexture, which is separate from the surrounding normal breast tissue. And it's very important that we see these non-mass lesions on two separate orthogonal planes. Otherwise, they could just be a normal breast parenchyma that we're mistaking for a non-mass lesion, and they should not have any convex margins. And the distribution could either be focal, linear, segmental, or regional. And similar to how non-mass enhancement is characterized in MRI, normal glandular or fatty tissue may be interspersed within the lesion as well. And associated sonographic findings such as calcifications, ductal changes, architectural distortions, they all increase the detection rate and they raise the suspicion of malignancy. Now that we have reviewed the various classification systems, it is evident that these frameworks have been created to underscore the need for the inclusion of non-mass lesion descriptors in the BIRADS lexicon, mainly because having the inclusion of non-mass lesions within BIRADS would help to increase the earlier detection of breast cancer. Because as we discussed, many malignancies, especially ductal carcinoma in situ and lobular cancers, can present as non-mass lesions. In fact, some studies have even shown that up to 60% of ductal carcinoma in situ can present as non-mass lesions. And a BIRADS category would ensure that there would be more consistent biopsy rather than follow-ups given to these patients. And it would also ensure that there would be a standardized management for these patients presenting with non-mass lesions. And this would enable the creation of uniform follow-up guidelines. Currently, some patients with non-mass lesions might not receive definitive management because of reporting ambiguity. And standardizing terminology would reduce such variability and improve audit and tracking, such as in the case of masses right now, which are being reported with the BIRADS lexicon and being given the BIRADS scoring system. And it would also help in the risk stratification, where explicit NML descriptors would allow more nuanced risk tables being created. And for example, if we had a non-mass lesion with segmental calcifications, they would be assigned a higher BIRADS category than a small focal non-mass lesion without calcifications. Similarly to how BIRADS 4 lesion is now subdivided by risk based on their margins, based on their calcifications. And consistent lexicon entries would help future studies also quantify the cancer probability for each subtype, and it would help to create and refine management guidelines. And also having a non-mass lesion subcategory within the BIRADS would improve communication between MR and ultrasound, and also when patients are moving across different setups, which is especially in the case in India, where we have a lot of patients referred from peripheries. And radiologists could, for example, they could report an MRI non-mass enhancement, and they could also note a correlating non-mass lesion on second look ultrasound as well. So how does detecting non-mass lesions on breast ultrasound impact the treatment course of a patient? So one aspect that we have to consider is that it would change the risk stratification and the way the patient is counseled. Mainly, it would indicate that there could be upgradation of the treatment intensity. So when a patient has a non-mass lesion on breast ultrasound, they have to be counseled regarding the fact that if on biopsy it proved to be DCIS, approx 15% of these patients could be upgraded to invasive carcinoma at surgery. And as compared to discrete masses, these patients may have a higher likelihood of re-excision. And in case these patients had underwent bracketing, non-mass lesions also have a higher incidence of being potentially converted to mastectomies as well. And also recognition of non-mass lesions on breast ultrasound, it fundamentally also alters the treatment planning by influencing the surgical approach, what the extent of dissection could be, the localization strategy, and as well as ultimately the feasibility of breast conservation therapy. So NMLs, they frequently necessitate bracketing localization techniques using multiple wires or radioactive seeds, so that we can delineate the full extent of the disease. And it's especially crucial when we're looking at a lesion whose span exceeds that of 3.5 centimeters. So this is the median size that requires bracketing. And also when we have multiple foci which is present within the same breast, and also when DCIS component shows non-mass enhancement pattern on MR as well. Another consideration that that non-mass lesion brings into picture is margin status and re-excision rates. So NMLs have a higher risk profile, particularly in non-mass lesions which contain ductal carcinoma in situ. They have shown significantly higher positive margin rates, with the DCIS presenting as non-mass lesions having almost about 23% of additional surgery rates. And overall, in NMLs which had bracketed procedures done, it showed that 21% of these procedures showed 20 positive margin rates. And coming to margin width requirements, for DCIS, which is presenting as non-mass enhancement, generally the 2 mm margin guideline is standard, but clinical judgment should also incorporate what the volume of the disease within the 2 mm margin is, and what the presence of residual calcifications on post-operative mammography looks like, and how the non-mass lesion is presenting. Is it multifocal, and the extensive nature of the disease? So all these things are considered when planning the breast conserving therapy. And coming to long-term management when it comes to non-mass lesions. So adjuvant therapy considerations, not much alteration is required. The standard radiation therapy remains as indicated post-breast conserving therapy. And the hormonal therapy decisions, again, this also remains unchanged by the non-mass pattern. But non-mass lesions have a bearing on the impact on surveillance and follow-up. Especially when we're talking about post-operative monitoring in the form of mammography. So follow-up mammographies for residual calcifications are always indicated, and bilateral screening intensification should be considered, because almost 19% of cases can show contralateral cancer detection, as proved by a study done in England. And local recurrence monitoring should also be intensified because it has a higher baseline risk. So now that I've spoken about how non-mass lesions has bearings on uh, uh, the management, I'd now like to talk about the various sonographic features with imaging encountered in non-mass lesions, starting off with the varying internal echo texture. So here we have three images of non-mass lesions, and each of these images has a different echogenic pattern. So non-mass lesions can present as predominantly hypoechoic, or they may be mixed hyperechoic with a few hypoechoic spotted areas within, or they may be predominantly hyperechoic, as seen in this image on the right. And as I've spoken about in various classification systems, the distributions can vary, and they may present as focal, small, confined areas, as seen in this illustration on the top, where we have a predominantly hyperechoic irregular area, which is confined to a small breast tissue. And we have the linear pattern, where it is a longitudinal area, or it's a segmental pattern, which is a triangular area arrayed in a line along the ductal distribution. So segmental distribution, it is the most sensitive and specific pattern, and for especially for DCIS, and it suggests the deposition of calcifications along a duct and its branches. And we also have regional distribution, which is a large geographic area which is not conforming to a ductal or segmental distribution. Then I've spoken about ductal architectural being considered in a lot of the classifications, and this is a nice example of ductal architectural, where in this patient, who 25-year-old, who presented with a palpable mass, we can see that there are several small anechoic areas which are aligned in a linear distribution, suggestive of a duct, and there are also some larger outpouchings or cystic dilatations around that duct. So this was a case of a complex sclerosing and papillary lesion, and with also intraductal hyperplasia and apocrine metaplasia. And again, we have these two images, and in both these images, we have the involvement of ducts. However, there are two different kind of pathologies. One is ductal carcinoma in situ, and another is a benign etiology of epithelial hyperplasia. So the enlargement of ducts in ductal carcinoma in situ, it's been ascribed to the tumor cells or necrosis within the duct lumen, and it's also causing this periductal lymphocytic reaction or periductal desmoplasia. And then so again, here we have these hypoechoic areas arranged in a linear fashion. And in epithelial hyperplasia, in this image on the right, we have a predominantly hyperechoic non-mass lesion with interspersed hypoechoic areas within. And again, mammographic asymmetries also does show correlation with non-mass lesions on breast ultrasound. Here we have a one view finding where on the lateral side of the RCC view, there's a possible suggestion of architectural distortion, and its correlate on ultrasound showed irregular mixed echogenicity lesion with the parallel orientation with the skin surface. And so this was another good example of how subtle findings on mammography can again be picked up on ultrasound. But if we were to see this finding on ultrasound uh, before we had seen the mammography, it could have easily been overlooked. So, which is why it's always better to use two modalities in conjunction to make sure that we are giving the best management possible for the patient. Here again, we have another 57-year-old woman who had come for screening, and on her in her left breast there's this architectural distortion seen, which on ultrasound again it correlates for the architectural distortion seen on mammography, and there is this vague focal area of mixed echogenicity. It's again predominantly hyperechoic non-mass area. Again, could have easily been overlooked on screening breast ultrasound, but because the patient also had mammography with her, it was easily picked up on breast. But again, these calipers really help in picking up the ultrasound finding. So on ultrasound guided biopsy, this patient turned out to have a complex sclerosing lesion, and on surgical excision, it turned out to be benign. And again, here we have another 69-year-old woman who came for screening mammography, and and the patient had architectural distortion seen in her left breast, and the correlate ultrasound done for the lesion showed an irregular, almost having indistinct, there are indistinct margins, and there's a mixed echogenicity pattern, and there are hypoechoic areas within, and it's a focal distribution. And this finding turned out to be invasive carcinoma with ductal and lobular features. So again, having this lesion have a focal distribution, we would not have expected much malignant etiology on pathology, but architectural distortion helped to distinguish it from a benign etiology. Then again, here we have another ultrasound image, which is a correlate for mammographic architectural distortion. So these are two images taken for us, the same finding in orthogonal planes. And on the right side, we have non-mass lesion, which appears as this oblong hypoechoic area. It's quite a nondescript finding, but on the orthogonal plane, we see that it appears a lot more suspicious, and it appears to have again focal distribution. But considering the correlate of architectural distortion and mammography, the ultrasound guided biopsy was done, and it turned out to be an atypical ductal hyperplasia, which on surgical excision again turned out to be atypical ductal hyperplasia. Another sonographic feature that we encounter in non-mass lesions is posterior acoustic shadowing. So posterior acoustic shadowing indicates pathologic changes inciting desmoplastic reaction that attenuates the ultrasound beam, and it's been described in both benign and malignant conditions. So here in this non-mass finding, we've mainly picked up this non-mass finding because of the posterior acoustic shadowing that it's creating. Once we see this shadowing anteriorly, if we look, we see that there is this focal area of architectural distortion and hypoechoic area, which again could have been easily overlooked had there not been this posterior acoustic shadowing. So ultrasound guided biopsy in this case again showed an invasive lobular carcinoma. This was another screening MRI, which was done for a high-risk patient. And on her left breast, we can see that there is this focal area of heterogeneous non-mass enhancement with a correlate of architectural distortion seen on mammography in her right breast. And on ultrasound, this lesion was found to be an irregular mixed hypoechoic area showing dense posterior acoustic shadowing that is almost like foretelling that this could be a malignant etiology. So this turned out to be a ductal carcinoma in situ pathology. Here again, we have a MR done for a high-risk patient. This was a patient who had history of left breast cancer and was previously treated with breast-conserving therapy. And on her annual screening mammogram, there was this plaque-like non-mass enhancement seen along her pectoral muscle, along with enhancement along the pectorals as well as along the pleura as well. And when correlate ultrasound was done, you can see that there is this segmental kind of distribution of non-mass pathology, non-mass lesion with predominantly hypoechoic in echogenicity and a little bit of posterior acoustic shadowing. So on ultrasound guided biopsy, this turned out to be grade 3 invasive ductal carcinoma. And another associated finding that we should consider is distortion. So architectural distortion, it mainly indicates pathologic changes that are distorting the ducts or straightening and retracting the nearby Cooper ligaments. And this mainly occurs because of cancer infiltrating the adjacent breast parenchyma. And also it can occur in certain benign breast lesions, especially the sclerosing kind of adenosis, as well as in fibrosis. So this can start to disrupt the parenchymal echo texture and without any visible mass, as seen in this image here, where you can see that there is this indistinct kind of non-mass lesion, but very obvious architectural distortion in the form of these radiating linear hypoechoic lines that we're seeing here. Next, we have calcifications, because calcifications are depicted on ultrasound, which are depicted on ultrasound. Some studies have shown that they're 3 times more likely to be malignant, and benign breast lesions such as fibroadenoma, radial scar, atypical ductal hyperplasia, and tubular adenoma can also present with calcifications. However, when you're seeing lots of calcifications in a segmental kind of fashion, as seen in this image, the main differential that we should consider is ductal carcinoma in situ, and also invasive ductal carcinoma, and less likely lobular carcinoma in situ. And but mainly when we're seeing them on ultrasound, we have to consider the first possibility to consider would be a malignancy, and other associated features like architectural distortion, ductal dilatation again points towards malignancy. We would less likely think of benign etiology, because generally calcifications as associated with benign tissue, they may be obscured by the echogenic breast parenchyma. Additional ultrasound features that we can utilize in determining these non-mass lesions is shear wave elastography. So how shear wave elastography works is that it quantitatively measures the tissue stiffness by calculating the velocity of the shear waves propagated through the tissues. So it adds both, it adds quantitative data beyond the grayscale and Doppler findings that are conventionally used in ultrasound. And generally, malignant tissues are stiffer than benign ones because of the desmoplastic reactions and the increased cellularity incited by malignant etiologies. And so shear wave elastography, it helps to differentiate inflammatory or benign fibrotic processes, which may appear hypoechoic and irregular. And so it can help to differentiate benign from true malignant stiffness. And studies have shown that for non-mass lesions, it's better that we use lower thresholds than that used traditionally for discrete masses. And they should, shear wave elastography data should always be interpreted in the context of morphology, other associated ultrasound features, as well as the clinical risk of the patient as well. So here in this image, we have this non-mass lesion with the red areas, these indicate areas of increased stiffness. So this was a case of ductal carcinoma in situ, where we can see a lot of areas in focal interspersed areas of increased stiffness, which is another additional feature that helped us determine that this could be a malignant etiology. Now, contrast enhanced ultrasound. So contrast enhanced ultrasound, it provides both functional perfusion information, which is not available on grayscale ultrasound. So malignant heterogeneous enhancement, perfusion defects, early wash-in, and rapid washout, all these features would help us think of a malignant etiology. Whereas in when we encounter homogeneous enhancement, iso or hypo enhancement related to the background, we would think of a benign etiology. And contrast enhanced ultrasound would also help us look for the lesion scope, which is the true extent of the lesion. So here it helps us to understand both the extent and the vascularization of the lesion. And studies have shown that contrast enhanced ultrasound does have a good sensitivity, almost about 90% good specificity, 85%, and overall good accuracy as well. And especially when, again, it's really good for differentiating DCIS and invasive lobular carcinoma from benign proliferative conditions as well. And understanding the true extent of the area would help to improve preoperative planning as when we're doing bracketing, and also it helps to guide us for targeted biopsy as well. So in this image, you can see that there is this hypoechoic area, which when contrast enhanced ultrasound was done, we could see that the true lesion extent was seen to be much larger than what was seen on grayscale images. In this next section, I'll be talking about our institute's experience with non-mass lesions. If we could please pause the recording now. Yeah. So coming to the conclusion of my webinar is that the appearance of non-mass findings on ultrasound, they can be subtle, and they're very diagnostically challenging, and a wide range of both benign and malignant conditions can present as non-mass findings on ultrasound. And features which raise strong suspicion are architectural distortion, nodular Cooper's ligament, and irregular intraductal calcifications as well. And mammographic lesions that most often present as non-mass findings on ultrasound include asymmetry, focal asymmetry, and architectural distortion. So they should always be correlated with the ultrasound as well. And non-mass findings on ultrasound also, they tend to appear as non-mass enhancement on breast MR. So it's always better to do a second look after finding NME on MRI. And structured assessment will improve the early diagnosis, and it avoids unnecessary biopsies as well. And we hope that the next edition of BIRADS, which is proposed to be coming out this year, will consider incorporating non-mass lesion descriptors into their BIRADS lexicon. So these are the references.
Thank you very much, Dr. Gurram. This was an excellent talk, and it was a delight to listen to you, because I was also involved in breast imaging in my previous job. So excellent talk. I have the first question is from Dr. Halka from Emory University. He says, great presentation, thanks and congratulations. On a different note, how prevalent is breast cancer screening in India? Dense breasts are a problem for mammography, and how often you see dense breast? Do you use system EB scans and myeloma in dense breast for breast cancer diagnosis?
Okay, so addressing the first question, how prevalent is breast cancer screening in the Indian setup? India does follow the same guidelines as the rest of the world, where we have patients older than 50 coming in for mammographies for breast cancer screening. However, there may be some setups which do not have a mammography available. So in such cases, then breast ultrasounds are done, which was the case for our institution as well up until recently. We do have patients coming in, getting clinically examined, and getting breast ultrasounds done whenever there is no mammography present. And we have a lot of the government of India also has several campaigns present, which we have done recently as well, where we have set up camps in peripheries, trying to reach remote areas as well. So yes, it is quite prevalent. And I didn't catch the next question.
So is dense breast a problem for mammography? How often do you see dense breasts?
So generally, we do not, dense breast is commonly seen in younger reproductive age group females, and mammography is not a screening modality in those patients. So we would use screening breast ultrasound for those patients. And but if we did find a non-mass lesion on breast ultrasound, or if a non-mass enhancement was found on MRI, then definitely, at least in our setup, we do go for a second look in mammography as well.
All right. And do you use System EB scans in dense breasts for breast cancer diagnosis?
So currently in our institute, that is not that is not the treatment protocol that is being used, but I would love to know more about what System AB protocol is for breast cancer, though. I will be certainly reading up about it.
Yeah, so System EB, I think it never gained much popularity, but Dr. Shankar also put in a question. So just a quick bit about System EB, and Dr. Halkar can chime in, and then we can talk about Dr. Shankar's question. Is that System EB is a non-specific tumor imaging agent. So then, there has been some interest in the past, especially for these dense breast and non-mass like lesions where, although it's non-specific, so that means fibroadenomas may light up. And in the past, so we inject something radioactive and do images in the same configurations as we do mammography, the CC and MLO view.
Okay.
Initially, there was go ahead.
I'm sorry, excuse me, can I just answer a few of the questions?
Sure.
I'm Dr. Annapurna, and I'm an additional professor at AIIMS Bibinagar. And along with Divya, we've been working on breast ultrasound as well as mammography. So to answer the questions which were first asked, the first thing is that in India, there is no government-sponsored screening program. Hello, can you hear me?
Yes, ma'am,
We can.
Yeah. So there is no government-sponsored breast screening program like how it is available abroad. It's more of an opportunistic, like people or women who are aware of mammography and the additional its advantages. They do turn up as a part of a master health checkup at many corporate setups for breast cancer screening. But then we do try in our level at the peripheries, especially because we are a little away from Hyderabad, and all the peripheral, the rural population does come to institutes for treatment. So we do try to encourage all women who come to us for other complaints as well, if they are above 45, to get a mammographic screening done. So, and also till late, we didn't have a mammo with us. So even those cases which had come for diagnostic ultrasound, we used to encourage them to get a mammography done, because that will actually help us in recognizing multifocal or multicentric nature of breast cancer. And then regarding dense breasts, mammography agreed. Initially, the digital mammography, the sensitivity of picking up lesions in dense breast was lower. So we used to do this adjunctive, breast ultrasound, especially in dense breasts, to pick up lesions. But now, with the advent of digital tomosynthesis, which is a 3D mammography, wherein the breast is imaged at various angles, and you have these slices of breast images coming up. They prevent this overlap of tissue, which is normally seen in 2D mammography, and therefore they actually help in picking up lesions more, and are more helpful in cases of dense breast. Not just that, but even the advent of contrast enhanced mammography. Once you give this iodinated contrast, especially in dense breast, it is acting as an adjunctive imaging modality for picking up especially non-mass lesions or multifocal lesions which could have been missed on 2D mammography. So with the advent of tomosynthesis and contrast mammography, I think mammography it can be used even for dense breast. Otherwise, in high-risk patients, we used to go more for breast MRI. So, and we do see quite a lot of dense breast. So say type C and D type of breast of BIRADS pattern, we encounter in around 20 to 30% of patients. And not just that, it has been seen that the dense breasts on mammography might not be age related. It is just the pattern of breast in the woman. So you can also see women who are postmenopausal, say above 50, in whom you expect the breast to involute and show more fatty changes. But usually the type D type of breast pattern, it persists throughout the age. So that was just my 2 points for that question.
Yeah, that is very true. The density of the dense breast has nothing to do with the age as much as one of the correlation may be BMI. Lower the BMI, more chance of dense breast, and higher the BMI, less chance of dense breast. That correlation is noted. Yeah, age or ethnicity also is not a good correlation between. But very well taken with tomosynthesis uh, is makes a lot of difference for dense breast. And I work at Emory, just like Dr. Saima, and Carl Dorsey was one of the faculty here at Emory who developed the BIRADS system long time ago. And he also was instrumental to develop tomosynthesis.
Thank you, Dr. Halkar. I'll take Dr. Maitri Shankar's question. What is your opinion on QT imaging / 3D ultrasound, acoustic ultrasound?
Divya, shall I answer the question?
Well,
3D ultrasound. So 3D ultrasound, we have not much experience with 3D ultrasound, and I don't think there are many 3D ultrasound, automated breast ultrasound machines or equipment available here. But then 3D ultrasound has been found to be quite sensitive in picking up mass lesions in the breast, and I'm not quite sure how it performs with the non-mass lesions. So our experience with 3D ultrasound is very limited. So if anybody in the audience has any experience with 3D ultrasound, you're please welcome to share.
Thank you, Dr. Anand Purna, on that. As I said in my previous job, I used to do breast imaging minus the biopsies. And I'm talking about somewhere in 2016-17 when there was a trend in US that people were moving towards automated whole breast ultrasound. But there were mixed opinions about that. And since 2019, I have not been doing breast imaging, so I'm not aware how things have progressed in that direction. But those were the times when there was a lot of interest, and a lot of breast imaging centers were getting whole body automated breast ultrasounds, especially for dense breast screening. And they found it superior to breast imaging, even 3D compared to 3D breast imaging. They found it, and then it was very standardized and reproducible, because here in US the ultrasounds are done by the techs, so they're very operator dependent, and then you don't know, if the tech did the ultrasound of the spot that really was the area of concern. With the automated, it becomes standardized. They go through all the quadrants. It's always done in the same way. So they are very reproducible in that sense. But that's what I know about them so far. I want to take everyone's question, which is in the chat. So I'll move forward. Sanjay Gambhir mentioned architectural changes with proliferation of cells, be it malignant or benign cells. So specificity may suffer as demonstrated in mastitis cases. How about combining a structural and an amoebi or FAPI? I think a part of that question has been answered earlier.
I'm sorry, I didn't get the question. How about combining?
Combining a
Structural
CT
imaging
scan.
with functional imaging like system EB or a PET imaging, which is a FAPI, which is a breast cancer, which is a tumor imaging agent, which
Yeah,
to the fibroblast in the cancer microenvironment.
true. But see, the functional imaging, where you look at the vascularity of the lesion and the uptake of the lesion, can have a significant overlap even on PET imaging, because per se, PET imaging is never used for diagnosing primary breast malignancies. It is more of a metastatic or a lymph nodal um, a staging modality. So especially in non-mass lesions, they might not show a significant pickup because it has never been shown to be very sensitive for diagnosis of DCIS components or even malignancies which have very low vascularity. So I think there will be a significant overlap even if you're using PET imaging uh, for a diagnosis of non-mass lesions. Maybe it is better to correlate between two primary breast imaging modalities, like say 3D mammo or a contrast mammo with ultrasound or an MRI with ultrasound, so that we increase the specificity of non-mass lesions. If anybody from the nuclear medicine has anything to add in this, you're most welcome.
I completely agree. And also the way PET images are done, they are more whole body. They are not dedicated breast imaging. And you cannot compare apples to apples if you're not doing the breast imaging in the same standard views that are standard for breast mammography. So it's hard to make a call just on the whole body images. One more question, Dr. Irfan Shafiq. Was there any correlation with elasticity imaging in these cases or in dense breasts?
Unfortunately, we could not perform elastography for all our cases. That would be another study that we would have to do to see how it would correlate with dense breasts as well. So that's another avenue of research.
So the elasticity, as we have seen, it could be higher even in cases of benign lesions which have got fibrosis, especially when they are chronic and healing type of lesions. But then the main role as given in literature of elasticity in non-mass lesions is to guide the biopsy. Like if suppose there were to be a non-mass lesion and we are seeing certain areas of intermediate or high degree of stiffness in the non-mass lesions, then those are the areas which I would like to target when I'm doing an ultrasound guided biopsy. So that is a known or more followed protocol. Just as Divya has said, maybe we'll have to see, we have to increase our sample size and look at a more number of cases and correlate that with elasticity, and maybe involve something like a 3D ultrasound imaging along with 3D elastography to look at how it would vary in different parts of the non-mass lesion. So I think that is actually something which is a very interesting study. We would definitely think of that in the coming months.
Yeah, this is Irfan. If you could hear me.
Yeah,
We
yeah,
can hear you.
Yeah. So actually, I was involved in that, but we are trying to get this as also as early screening and to do the the elasticity in breast tissue, especially dense breasts, and it really turned out to be very, very sensitive. even more sensitive than, as you know, the regular mammography misses quite a bit of those patients, but it's quite, then we would do, after that, we'll do the ultrasound and see if there's a lesion there and then do further. So it was a lot more sensitive than any other modality so far. So it's been, now they're doing that, but it's not been, a few studies have been done. One was at actually at GW, George Washington University here. And I think one they're doing in Wake Forest, I think they're doing now. So it's very interesting. See, that's why I said it is region, but that would be a very good study to, if next time you do, to add that to it, which will make it more reliable and see which modality really picks up the best and what can be done further. I agree that there are some fibrotic lesions, but those are, later on, a patient had already had some things done to it, then it may not be as specific, but in other, the sensitivity and specificity was really high. Anything which is hard, it's quote unquote first considered malignant than anything else, as you know, unless there's a known lesion and there's a fibrotic changes otherwise for prior issues. So that was just a comment here for you.
Thank you, Dr. Shafiq, for your sharing your experience. And I think it's time to wrap up. Thank you very much, Dr. Gurram and Dr. Annapurna Bhatia. I am sure I think I'm pronouncing your name right. An excellent talk and excellent insight. Have a nice rest of your day.
Thank you very much for giving us this opportunity to present our work. And it would be great to interact with all of you in future and collaborate maybe on some research projects. Thank you very much for encouraging my student to participate in this webinar.
Thank you.
Thank you. Thank you.
Thank you, Jyotsna, ma'am.
Yeah, it was a wonderful talk. I really enjoyed it. Just one small question. Do you think artificial intelligence could help with this in reporting, or is that something one can look at?
Yes, actually, artificial intelligence, I think in breast imaging has been coming up in a very large way, because already there are so many studies being performed on, say, the risk of breast cancer with the density of breast on mammography, or detection and enhancement of lesions. Actually, we are planning on one particular study with the non-mass lesions on ultrasound. And now that we have mammography with our collaborators from IIT Hyderabad, to see how artificial intelligence would help in detecting and diagnosing of non-mass lesions. Yes, it definitely is the future.
Yeah. Thanks. Thank you very much. Thank you.